This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2017, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is COPD Case Management by Respiratory Therapist. Krystal Craddock is a registered respiratory therapist and COPD case manager for the Department of Respiratory Care at UC Davis Medical. Ms. Craddock has disclosed that she has served as a consultant for Monaghan Medical and Philips Respironics. This presentation is sponsored in part by an unrestricted educational grant from Monaghan.
Welcome everyone. This is the lecture COPD Case Management led by Respiratory Therapists. I will go over some of the objectives we have today. Number one, we're going to describe how RTs play a role in the interdisciplinary care of COPD patients within the hospital. Number two, we're going to list the CMS guidelines and discharge planning of a patient hospitalized for COPD. And the third objective today is to list elements of education and coordination for a hospitalized patient with COPD. So COPD is a challenge. First off, it's the third leading cause of death in the nation. 1 in 5 patients are readmitted into hospitals with COPD exacerbation within 30 days. 78% of direct cost for COPD is due to hospitalizations and exacerbations. So this means the cost of the readmission, the hospitalization, medications, missing work, 78% of those total costs are due to exacerbations of COPD. And over $50 billion now in total direct costs to the nation for COPD. So the Hospital Readmission Reduction Act under the Affordable Care Act was designed to provide incentives for hospitals to come up with programs and strategies to reduce unnecessary hospitalizations for COPD. And the key word here really is unnecessary hospitalizations. We can't prevent all admissions for COPD, all readmissions, but there are certain unnecessary ones that CMS looked at and said we can do better for these patients. So within 30 days, when a patient is readmitted for acute MI, pneumonia, and CHF in 2012, hospitals were penalized for these patients for any readmission within 30 days. And then later on, COPD, total hip, and total knee were added in October of 2015. So we want to identify the problems. With COPD, public awareness really still remains poor for these patients. COPD is not well known. Many patients don't really understand their disease, and the public is really unaware of it compared to other diseases such as breast cancer or heart failure. Preventable deaths occur daily with COPD. COPD is mostly a preventable disease, and so these deaths occurring daily are a real issue. 1 patient dies every 4 minutes from a COPD. And COPD patients are seen but not heard all the time. They're seen in their doctor's offices, but are they really reporting their symptoms correctly? Are they talking to their doctor, having conversations about treatment and management of their disease? And then empathy is not common enough. Empathy for every COPD patient is necessary. Empathy is not an occupational hazard, and it's something that us as respiratory therapists and COPD case managers, we can really use to help our patients, help make them feel comfortable, which will in turn help us treat them better. So at UC Davis, we developed a quality improvement program for COPD care. We wanted to improve the standard of care for COPD patients. We want to make sure every patient hospitalized with COPD is seen and educated by a respiratory therapist. We want to increase public awareness in this way and get our program out into the community so other hospitals and patients can hear about what their disease is and how to better treat it. We integrate and synchronize COPD services within our hospital. We work closely with our hospitalists, our discharge planners, our pharmacy technicians, our pharmacists, and our bedside nurses, of course. And then our other overall goal was to reduce admissions, hospitalizations, and readmissions for unnecessary COPD exacerbations. We looked at some of our numbers at UC Davis before we started our program. It's really important to look and see where your hospital is at and look at the data where you're working. And so in fiscal year 2009, we had 459 admissions for COPD, which then increased in 2011. Total direct cost to our hospital was over $15 million. And we also had an increasing length of stay. The national benchmark for a COPD hospitalization is about 4.4 days. We were up to over a week at our healthcare system, so we saw that as being a problem that we could probably impact and fix. And then increasing cost of hospitalizations. Prices of everything are going up, including costs of admissions for COPD and other hospitalizations. So we went from, in 2009, from 14,000 and nearly doubled that in fiscal year 2011. So our COPD case management team was created, and what our goal is to provide our patients with education on their disease, make recommendations to the physicians and the interdisciplinary team to help transition our patients home safely and help them manage their disease at home. We have 4 education sessions within our education program at UC Davis, and it is done at the bedside during their admission for hospitalization for their acute COPD exacerbation. We use different teaching techniques. We don't just sit there and talk at the patient or talk to the patient. We use different devices to show the patient about their disease. We have videos on their anatomy and physiology of the normal lungs versus the COPD lungs. We use lung and airway models so that the patients can have a hands-on look at what their airways look like with severe bronchospasm. We do illustrations. We have nice pictures of the airways and lungs and different medications for the patients to look at. We have device demonstrations. So when we're going over our patient's COPD home regimen of their inhalers, we're using these devices to show them how to perform their therapy correctly. We use bubbles to practice pursed lip breathing. We, of course, give our patients handouts on everything we covered in their education session. And we use different equipment as well to show them about portable oxygen concentrators, oxygen tanks, and non-invasive ventilation. So the first CMS discharge planning standard is the identification of a patient in need of a discharge plan. We want to identify patients early on in their hospitalizations. These patients are patients with multiple comorbidities, patients who are high utilizer of the emergency department, the hospital, of their primary care. And these patients are identified as needing a discharge plan by CMS standards. The discharge planning evaluation happens within the first few hours of identifying the patient. So once the patient walks in, within the first 24 hours, we're going to identify the patient, and then we're going to evaluate them shortly after. The evaluation includes bedside monitoring of a patient, evaluation. We want to see where the patient is going home to, who is their support system, do they have any durable medical equipment, and so on. The actual discharge plan is used to really provide the patient with education, to come up with a plan as an interdisciplinary team to make sure that the patient is transferred home or wherever their skilled nursing facility or rehab facility safely. We want to improve our education during this discharge plan. We want to give the patient written discharge instructions per CMS guidelines. We're going to provide supplies that are immediately needed for patients who are being discharged at the time of their discharge, and a list of all their medications that the patient should be taking. So when the patient comes into the hospital, if they're taking a list of medications, we want to make sure that we say either stop this medication, start this medication, and continue these medications. We want to give the patient a detailed list of this, as well as where to pick up their medications from which pharmacy. And then the fourth CMS standard for discharge planning is the transfer or referral. And that is just basically the transferring of the patient from the hospital to their home and making sure that the plan goes through smoothly during that transition. And then reassessment. Reassessment's important. A lot of practitioners think of the reassessment part of the CMS discharge planning as reassessing the patient during their hospitalization, which is true, we always want to do that. But when CMS is talking about their discharge planning standards, the reassessment is reassessing the overall picture of your healthcare system's discharge plan. You're going to look at readmission rates, really, is the key to the reassessment portion. You want to make sure that when patients are going home, there's not a ton of unnecessary readmissions. And when you see that during your reassessment, you got to think, what can we do better at our healthcare system? So in our COPD case management program, we're going to first identify our patients. We will see all patients admitted into our hospital with a COPD exacerbation. We use an electronic medical record screening tool that is emailed to each case manager every morning. And for patients to populate on this tool, they need to be over the age of 40 and meet 3 of the 5 following criteria. 1, they're on a scheduled bronchodilator. 2, there is an oxygen order. 3, IV antibiotics. 4, an order for steroid. And 5 is the diagnosis. So we made the diagnosis broad, so it's not just COPD, emphysema, chronic bronchitis. We added shortness of breath, pneumonia, asthma, many diseases, so we can really capture patients that may not have that clinical diagnosis of COPD yet, but are in need of pulmonary function test, education, and follow-up as an outpatient. When we meet with our patients at bedside, ideally we do not want them in the ICU. The ICUs can be hectic and loud and crowded, but you know, we will see the patients if they are in there and they are not going to be transitioning to the floor anytime soon. As long as they're not needing any critical care such as a non-invasive ventilation, or of course if they're intubated. If there's a language barrier for our patients, we are going to set up an appointment with a translator to come and meet with us at bedside so that we can have a good discussion with our patients. We tend to not use the translators over the phone. We would like them to be there live, but of course if they could not make it, we will use the phone translators. Able to participate and appropriate for the education. We need to make sure our patients are willing to participate in education and of course are appropriate, so they're not critically ill, requiring non-invasive ventilation, and they do not have a severe psychiatric history or going through withdrawals at the time of our education, of course. We always encourage our patients to welcome their families to come in and join us on the education. It's always great to have an extra set of ears within the room so that the patient, if the patient misses something, the family may pick up on it. The family also provides us with a lot of information about symptoms of the patient that the patient may not recognize, that the family happens to. We want to assess every patient when we first meet with them. We're going to go over their past medical history with their breathing and other comorbidities, their symptom history, how often are they using their rescue inhaler every week, how many times are they waking up at night with shortness of breath. So we really go into depth on their symptom history. And then, of course, their COPD treatments that they do at home. We will also do a COPD assessment test at the time of our meeting with our patients. And what we do is we want to get a picture of how they are on a normal day with their COPD. So we make sure to explain to them that we want to know, prior to this hospitalization on a normal breathing day, how were your breathing symptoms? We use this tool so that later on, after their education, after making recommendations to the hospitalist and changing possible medication recommendations, we want to see if it has made an impact positively for our patients. We, of course, always want to remember the A, B, C, D, E, F of COPD. And this is a term coined by our medical director, Dr. Samuel Louie. And we look at this list and think, is our patients on this? Are they on these treatment plans? Are they getting these treatments? Or do they need to be on these treatment plans? So A for anticholinergic, long-acting, of course. B, beta agonists. Are they on a long-acting and a short-acting? Are our patients on any corticosteroids, inhaled or oral? Daliresp is a medication that is recommended for patients who, to prevent exacerbations of COPD. Exercise and education, really important for our patients to be educated on their disease and to exercise to improve their endurance so that they can do normal everyday activities without getting so short of breath. And then, of course, flu shot and friends. We want to make sure our patients are up to date on their immunizations every year, really, but prior to when they leave the hospital, when we see them, of course. And then friends is that social support. Friends and exercise can go hand in hand when we recommend our patients to pulmonary rehabilitation. So our first education session at the bedside with our patients is, what is COPD? We want to go over the lung anatomy with our patients, normal versus a COPD lung. So we'll show them a normal airway and then an airway with chronic bronchitis, normal alveoli, and then emphysema, so that our patients can really see what's going on inside their lungs. A lot of times it makes a lot of sense when we go over these things with them. When they look at their lungs and they think of how they're breathing, it all starts to come together for our patients. The causes of COPD. Many patients don't know what caused their COPD. Diagnosing and staging COPD, they also don't understand how it was found that they have COPD. So we go into detail over how their COPD was caused, and then the pulmonary function test that really helps determine whether the patient has COPD or not. We talk about different treatments for COPD, not just medications, exercise, pulmonary rehab. We talk to them about non-invasive ventilation if they're in need of it. So all sorts of treatments for our COPD patients we really go over with our patients to educate them. The more you educate your patients about the different treatments, the more willing they are to be participants in their discharge plan. And participating in their discharge plan has shown that patients are more adherent to their treatments when they're participants in the planning of their discharge. And then we want to talk to the patient about slowing the progression of their disease down. If they're current smokers, we'll do bedside smoking cessation with our patients. We want to talk to them about exercising and taking their medications the right way to slow their progression of the disease down. The key to this education session, though, is that COPD is very treatable. Many times patients feel hopeless, they feel helpless with their disease. No one's ever sat down and really explained it to them. I've had patients tell me, yeah, I know what COPD is, there's no cure, there's nothing I can do. And that is something that we want to change. We want our patients to know that this disease is very treatable and that there's someone here to help them treat their disease. In education session 2, we go over the medications for COPD. And with medications for COPD, in our program, we found out that there were a lot of missteps. There were missing pieces to their puzzle. We went over rescue medications versus maintenance medications. Many times our patients don't understand this. They're given inhalers, several inhalers, and said, here you go, take these as directed and follow up later. So we really take the time to sit down and say, these are your rescue medications. This is what you're going to take when you're short of breath. And these are your maintenance medications, the ones you're going to take every day, about the same time of day, no matter what. We go over the different classifications of medications in layman's terms, of course, so that our patients understand that you need more than one inhaler to treat this lung disease. We go over the basic method of action and then the inhaler devices. So for each inhaler, we know that there are different devices. So we want to make sure we can show the patient the device prior to their discharge, especially when we're changing the medication regimen. But if we're not changing the regimen, we're still going to go over it because, like I said before, a lot of times patients are just handed their inhalers and told to follow up, and they don't understand how to use them correctly, which is a waste of time and a waste of money for our patients. We're going to go over prednisone during this education session. A lot of our patients know what prednisone is. They know it's that medication that helps them breathe when they take it when they're having an exacerbation. Sometimes they're going to be on a burst. Sometimes they'll need to be tapered off. And so we're going to explain to them why it's important to follow the directions on their prednisone use and exactly what it's used for and what it's doing inside their lungs. And of course, pulmonary hygiene. Pulmonary hygiene is really important for our patients as far as coughing, using different devices to help them clear the mucus out of their lungs. The medication changes and recommendations we make in our program for our patients are based on the GOLD guidelines, of course. And then we want to see, are they appropriate for our patients? Is the patient using their inhalers? Are they using them the right way? Can they afford their inhalers? Or can we do better? We look at all of these things and we've found gaps in these over the years, and so it's really important for me to go into this right now. Patients, many times you'll see come in the hospital on a certain medication regimen that looks very appropriate. They're great inhalers. Their doctor wrote them for all the A, B's, and C's of COPD. When you go to call the pharmacy to see if the patient has any refills or if this is their actual regimen, you find out that the patient may have not picked up their medications in a few months. What we were finding was that patients couldn't afford them when they went to the pharmacy and their bill was hundreds of dollars. They just said never mind and left without communicating with their physician about their cost issues. So what we're doing in the hospital before they're discharged is we're looking into their insurance and we're seeing which medications are covered under their plan and which classifications we can recommend for that patient so that we are sure that they are going to the pharmacy and picking their medications up every month and it's within their copay. We have patients who are not using their devices the right way, and as I said before, it's because they're not shown how. So we really sit down with them, show them how to use the device, and of course ask for a return demonstration prior to discharge. We also have patients who are very severe in their disease or have a very large tongue, and maybe the medications aren't getting down into their lungs. Maybe they're not able to have a great inspiratory flow and breath hold. So those patients we will tend to move to nebulized medications and we'll get that set up prior to discharge. During education session 3, we go over the signs and symptoms of an acute exacerbation of COPD. We want to talk to them about the early signs and symptoms so that they can call their doctor early and prevent unnecessary readmissions and get treated at home. But we also want to talk to them about bad breathing days. Everyone has bad breathing days. The air quality might be bad. We want to talk to them about avoiding their triggers and what to watch for and see, is this just a bad breathing day or am I really going into an exacerbation? We go over breathing retraining during this session. We talk to them about pursed lip breathing, and we really instruct them and encourage them to do that. And coping with shortness of breath, we go over the dyspnea cycle with our patients. Our patients with anxiety have a lot of issues. Once they get anxious, then their dyspnea increases, which makes them more anxious and then more dyspneic. So we want to talk to our patients about breaking that cycle. We might make recommendations to them on things they enjoy doing and ways to kind of get away from whatever stressful situation is causing their shortness of breath. We want to talk to them about preventing exacerbations. The #1 cause of exacerbations is infection. So we want to talk to them about infection control, washing their hands, getting their flu shot and pneumonia shot when it's due, and making sure they avoid sick people at all costs. Exercise in COPD is really important for our patients. We want all of our patients to go to a pulmonary rehabilitation facility. So we'll discuss pulmonary rehab with our patients, explain to them that it's not so scary, we're not going to make you run a marathon or anything, it's all at your pace. It's an individualized plan with education classes and of course that social support that they also need. At this time, we will work on referrals to not only pulmonary rehab, but smoking cessation for our patients who are current smokers. We'll provide the bedside education, but we want to make sure they have tools to follow up with after they're discharged as well. Our last education session is really an overview of what we covered. We want to make sure that the patient demonstrates that they understand what we went over with them. So we will ask for a teach back and kind of quiz our patients prior to leaving, saying, can you show me that pursed lip breathing we went over yesterday? And what are some of the treatments for COPD? What are your medications? So we really want to make sure our patients really understood what we were saying, and the family members as well when they're in on the education sessions. Oxygen use, we will go over the safety and travel with oxygen for our patients. Not only our patients that are new to oxygen that are being discharged, but the patients who are on oxygen. Sometimes we'll have patients who have been on oxygen for years but are afraid to leave their house and they don't think that they can travel anymore. And we want to let our patients know that oxygen isn't to hold them back, it's to actually make their breathing better, make them feel better, and be able to go places and see things. So when we have a patient who may be just on a home concentrator and some tanks that are too heavy for them to carry around, we'll work with the DME companies to see if we can get them on something like a portable oxygen concentrator so that they can go out and do more things every day. We evaluate our patients for obstructive sleep apnea. We know there's an overlap in people with OSA and COPD. So we'll evaluate them and refer them to a sleep clinic as necessary. And then we will review their road action plan. So we will go over their medications, their individualized treatment plan for their COPD. There's a colored picture of the medication on the plan. There's instructions of use and a description of the medication so that our patients can see their whole COPD picture and treatment plan on one paper. And then I encourage them, of course, hang it on your fridge, really get to know your plan so that when you go into your doctor's office, you can name the names of your inhalers and not just describe the color and the shape of them. After discharge, we do follow-up calls for our patients. It's really closing the loop. Patients need somewhere they can call to ask questions. So we have a COPD phone line in our hospital that the patients can call and leave a voicemail with a question. We check it, of course, throughout the day, every day, and we'll follow up with our patients when they call us. We will also provide our own follow-up calls to the patients 3 to 5 days after discharge. We want to make sure our patient either made their primary care appointment or is reminded of the appointment we made for them. And we want to make sure that they still understand their medications. We'll quiz them over the phone again. What medication regimen are you on? So that they can teach back and let us know that they know which inhalers they're taking every day. And then 6 to 8 weeks after discharge, we'll do another follow-up phone call. And this is when we reassess the CAT test and see if there is an improvement. This tool lets us know whether the patient really improved and what we did was right for the patient by, of course, educating them, which is always right, and then making any changes to their regimen. But also, we'll use it as a tool to help patients realize that maybe they need more. Our patients who weren't willing to quit smoking yet and their CAT test did not improve. We can use this tool to explain to them, your breathing's getting worse, now is the time to really think about quitting. Or even going to pulmonary rehab. You know, your score hasn't improved much. I really think pulmonary rehab is what you need to do to really help with your daily breathing symptoms. And then, of course, our pager access is available to all of our patients as well. So if we don't get a phone call, answer their voicemail within a timely manner, they're able to page us while we're out on the floor, and we can call them back and make sure that we answer any questions that they may have. We have patients who are not appropriate for lengthy education sessions at bedside during their hospitalizations. These patients that are not appropriate are usually severe psychiatric history, patients who are going through current ETOH withdrawals, current drug users, patients with dementia. We don't normally tolerate a lot of education at the bedside, especially those lengthy education sessions that we were giving to our patients. So we wanted to make sure this patient population does still get education and get the treatment that they deserve. So we will provide bedside education, showing them what COPD is, the different treatments for COPD, when to contact their primary care physician during an exacerbation, and then a road action plan. We get straight to the point. We try to make our education session about 30 minutes long with these patients at bedside. But then behind the scenes, everything else, we're going to do exactly the same as our road patients. We want to make appropriate medication recommendations based on the patient's COPD disease and, of course, their insurance coverage. We want to make referrals as needed for these patients, and we want to make sure that it's the same as any other patient admitted for a COPD exacerbation. So we do just as much work behind the scenes for these patients as our other patients. It's just the education that we modified a little bit. What we found with our patients within our COPD case management program, we had about 60% of patients who were women, average age of 68 years for all of our patients. Only 14% of our patients had prior COPD education, and those were during pulmonary rehab sessions. We had 69% up to date with their flu vaccine, 61% with their pneumonia vaccine, respectively. And then we looked at our patients with overlap syndromes. Asthma COPD overlap syndrome was 28% diagnosed. Anxiety was lower than what we think it truly is. We had 36% of patients with diagnosed clinical depression or anxiety. We think it's much higher, but that the patient isn't being evaluated properly, possibly. And then we had patients with COPD OSA overlap at 17%. 71% of our patients followed up with their primary care physician within 2 weeks after discharge, after meeting with our COPD case manager. 29% of our patients quit smoking. That was with a 6-month follow-up after bedside smoking cessation with an RT-COPD case manager. I really attribute this to 2 things. One being we're taking the time to sit down and talk with our patients and really inform them about smoking cessation. without just handing them a pamphlet and telling them to read it and follow up when they leave. We want to make sure our patient understands, and we really do provide good bedside smoking cessation. Also, our patients are admitted for an acute exacerbation of COPD. These patients come in the emergency room, they're scared, they can't breathe. And so when we're doing this bedside smoking cessation, they remember that, and they think now is the time that I really need to quit because I don't want to go through that again. So we had a really good success rate with our patients who we provided bedside smoking cessation to. The average CAT score improvement was 4 points with a 24% response rate. Of course, we did show a great improvement with that, but we did use the tool when we had patients who didn't improve to see if we could get them to quit smoking or go into pulmonary rehab or really be adherent to their treatment plan. And then 66% of admission required changes or addition to their COPD medication regimen. So what I talked about earlier was identifying patients and looking at their medication regimen, making sure it's appropriate for them, that they're on all the right classifications of medications, but that also their insurance is covering it and that they're picking it up and taking it and using it, and that they're using it the right way, and that, you know, patients may need to be changed. And it used to be when patients would come into the hospital prior to the hospital readmission reduction program, is the physicians weren't always changing home medication regimens that were prescribed by a primary care doctor. They would keep them the same and say, follow up with your primary care. With the new CMS guidelines, we can't do that anymore. We're changing our way of thinking. And so we need to make recommendations now. We need to do changes now to improve our patients' care right now. Looking at our outcomes for our COPD case management program, for our road education cohort, those were the patients that got extensive education at bedside during their hospitalization. They got those 4 education sessions, about an hour at bedside each. For those patients, our length of stay was decreased from over a week down to 5.17 days. A couple things we think of. Before we started our program, our patients were coming into the emergency department and greeted with a respiratory therapist where we were starting their continuous nebulizer or putting them on BiPAP. Once they weaned off of that and moved to the floor of our hospital, they may have not seen a respiratory therapist their whole hospitalization because we were primarily critical care RTs. So we were thinking that maybe, possibly, these patients were having such a long length of stay because they weren't being followed by RT. We weren't making recommendations as far as their treatments. They were just getting nebulizers every 4 hours as instructed by the hospitalist. The nebulizers were given by nurses who may have not had time or felt comfortable making recommendations. So these patients who once before would come in missed by respiratory therapists are now being followed closely every treatment, every day, and provided education. We really worked in an interdisciplinary approach to work on getting the patient healthy and getting them home. And we actually were able to decrease our length of stay with that, with a cost savings of a little over $8,000 per admission. Our readmission rate within 30 days was decreased to 6.6%. In fiscal year 2011, we were at 16%. So we had a projected cost savings for a reduction in COPD readmissions with a little over $500,000, with a total projected cost savings of our 4-year data at $2.2 million. For our cohort of patients, our pharmacy patients, the ones who had difficulty with bedside education and tolerating it, the ones we really focused on doing a one-time education session at bedside, are patients with severe psychiatric issues, patients with ETOH withdrawals or current drug abuse. We wanted to look at that data as well for those patients. So for that cohort, our readmission rate reduction for 30-day readmissions was down to 6.4%. This goes to show that the bedside education is important, but we also need to do all of the case management on the back end for these patients. We really need to make sure we're making appropriate follow-up appointments for our patients who can't do it themselves. And a lot of our patients within this pharmacy cohort had that issue. These patients are assigned to a medical insurance and assigned to a clinic or a practitioner, but they really don't understand how to navigate the healthcare system. So we really take the time on the behind the scenes part for these patients to call their insurance company, find out what clinic or provider they're assigned to, and then call that clinic or provider to make a follow-up appointment for these patients. I can tell you personally that the appreciation that comes from these patients for doing such a simple task was great. And this lets me know that not everyone is able or understands how to call and make a follow-up appointment. Or once they call and they're on hold for so long, they just hang up the phone and give up. So they really need people to advocate for them and to help make these appointments for our patients. We also made recommendations for these patients that changed their outcomes drastically, as you can see. These patients, those 66% of patients that were on the wrong COPD regimen at home that we ended up changing prior to admission, really shows that you can make a difference by not only education, but educating not only the patient, but the physicians, the pharmacy, and working with the insurance company to find out what things we can recommend for our patients to make sure that they can be successful in treating and managing their own disease at home. A development of a quality improvement program for COPD care offers benefits for the hospitals with COPD admissions and readmissions on the rise. I believe every hospital in this nation should have a COPD case management program, and it should be led by respiratory therapists. We are the expert in pulmonary diseases. We don't require much more training in the disease as we've worked with it through our careers. We really do need to take time, though, to make sure that we're up to date on all the new treatments out there, new studies going on for our patients, and of course the new medication regimens. I recommend making friends with your durable medical equipment companies within your area, really learning what they're about, who they are they about the patient, are they about improving the patient's care and outcomes, as well as the different medications. Pharmaceutical representatives and educators are great people to keep in contact with. They should be bringing you demonstration devices so that you can go over the treatments with your patients. You should be learning about all the new medications and inhalers coming out for your patients with COPD so that you can be on top of it in order to provide education to the hospitalists and pharmacists as well. Respiratory care practitioners perform a vital role in integrating the COPD care by improving the patient education and coordination of the patient care services. As our program has shown, the COPD case management team, all of our case managers are respiratory therapists. We're the ones really coordinating this interdisciplinary approach. Before, it was very cut off. We were not all working together to care for these patients. And as I've shown from our cost savings, we have really proven that working together, coordinating with the different disciplinaries and making recommendations to our patients has really reduced our cost savings. And then respiratory care practitioners facilitating healthcare navigation and utilization for COPD patients result in improved outcomes and cost savings for the patient, the hospital, and the patient's medical insurance company. We're really helping the patient navigate the healthcare system, understand there are treatments out there for them, that their disease is not curable, but it's very treatable. And we can treat it with different medications and recommend them going to outpatient services that they were not aware of before. Many of our patients don't know what pulmonary rehab is before they're hospitalized. And so we want to make sure that they know that there are more options, not only medications, but there's exercise that can help improve their breathing. There are social support groups out there for patients with COPD. And we want to make sure that our patients understand that as COPD case managers, as respiratory therapists, sitting down, being empathetic to them, and really helping them understand how to navigate, and with us helping facilitate their treatment, that they can be treated properly and stay out of the hospital and feel better, improve their quality of life.